Hey guys, it's Jamesia Capri, the nurse practitioner extraordinaire. If you're new to my channel, welcome, welcome, welcome. Please like, comment, and subscribe. Here we discuss all things NP, the good, the bad, and the ugly. Let's get it.
That's being injected into the tissue.
Okay.
So some of the newer diabetes medications, and again, some of these have been on the market for several years. SGLT2 inhibitors, so those are the medications that decrease the sugar reabsorption in kidneys. Just a lot of fantastic research supporting the use of these. Now, there are some precautions that have to do with renal function, and so you would definitely have to take a look at that. But this is actually recommended sometimes as a second-line treatment if patients have a history of congestive heart failure. So again, there's an algorithm that will kind of lead you to that. These drugs have pretty much been proven safe. There is a small risk of DKA, so diabetic ketoacidosis, and that's actually on the labeling. But these are great medications. DPP4 inhibitors, these basically are working on the gut. So one of the metabolic pathways for controlling blood sugar in the body is actually the gut hormones, which are released in response to blood sugar elevation. When you have type 2 diabetes, your gut hormones are basically, non-existent. And so these are some great medications for that. As a matter of fact, when people have gastric bypass surgery, one of the things that happens is their gut hormones are restored, which is why their diabetes goes into remission. Also, the GLP-1s, they're similar to DPP-4s, but maybe I would say have a little bit more oomph to them. The great thing about these medications, of course, is that they're not insulin, even though it's an injection. So patients always say, oh, I don't want to take insulin, even though it certainly can save their life. But what's nice is that the GLP-1s only respond to elevated blood sugar. So they're not making your blood sugar go low. They're only responding to when blood sugar levels are actually going up. And so it's really telling your pancreas to also release more insulin. The slower gastric emptying is awesome because, again, if from the previous slide, when you have diabetes, it's kind of a double whammy. You are hungrier more often because your digestive system really is emptying out faster. There's the promotion of satiety, and then the suppression of glucagon. And glucagon is the hormone that is produced by the alpha cells, and it tells the liver to release sugar. So the glucagon actually works opposite of insulin. That's how you can look at glucagon. This is the algorithm that actually this is a kind of a medication sheet that goes through all the different the oral medications for diabetes. And this is what you will find in the standards of care. So I know you can't read this, but I'm just letting you know that you can actually go out there and find it. So it starts with metformin. It goes through all the orals. It tells you the efficacy, the precautions, all of those things. So it's really a great reference. And then the next sheet is,
and they can find this where, Stacia, on which website can they find this?
So I think the third slide, which talked about the standards of care from the American Diabetes Association, at the end of that slide, I put the website. That's where they can find it at.
Right.
So this book that you see right here that says Standards of Medical Care, that's where they will find that information.
Okay.
There's several chapters in there. One of the chapters is glycemic approaches to diabetes. So that's where they'll find it at.
Very good.
Yeah.
Thank you.
And this is really the algorithm, for the question about what's your second line treatment. It's not one size fits all. So again, this is from the same reference, the American Diabetes Association Standards of Medical Care for Diabetes. This actually goes through how you would treat someone with diabetes. And at the top, it talks about first line therapy is metformin, right? Second line therapy, okay, where do you go? If they have a high risk or have established cardiovascular disease or heart failure, then they would go and they would take there's a green box and a red box. So they would go and they would either take a GLP-1 or they would take an SGLT2 inhibitor. So they would either take Trulicity, Ozempic, those drugs, or they would take the Invokana and the Jardiance. And they've actually been able to show that patients have less hospitalizations for heart failure, number one. Number two, there's actually less mortality from cardiovascular disease when people are starting on these medications ahead of time. If they don't have a risk of either one of those things, then you have to look at, how do I individualize this treatment? Is cost an issue? Well, the box to the right, to my right, I guess. The green box talks about using sulfonylureas, things like that are a little bit cheaper. If there's a compelling need to minimize hypoglycemia, so for example, with the geriatric population, there are some great options, DPP-4 inhibitors, GLP-1s, those things don't cause the hypoglycemia. And then if you're looking at weight gain, because obviously insulin does, unfortunately, it doesn't cause weight gain, but people do gain weight when they're on insulin. But anyway, there's some information there too. So again, I would definitely encourage you to take a look at that.
Okay, very good.
So this is really estimates, but it gives you an idea of how much all of these different medications and regimens lower A1C. And you can see right at the top is metformin, which is one of the reasons why it's a first line treatment. And then second is the sulfonylureas. The caution, of course, with sulfonylureas is that you have to remember how they work. They work by telling the pancreas, give me some insulin, right? And so there's a risk of low blood sugar because patients will take it and then they'll get a phone call and they'll forget to eat. And the next thing you know, they're on the floor and they're in the hospital. So we do see that quite a lot. And so I always say to use this with caution. The other challenge with sulfonylureas is that they definitely can kind of make the pancreas work all the time, which can lead to a little bit more of the progression of beta cell loss.
Okay.
Prandin and Starlix, you don't see those very often, but I would call those more modern sulfonylurea. So in other words, you literally take those right before you eat a meal. Don't see that very often. Actose is a TZD, so those have some opportunities as well. And then you can see the rest of the list. At the bottom is insulin. There's no ceiling. So there's no upper limit for insulin, which is what makes it great.
Okay.
There was a question about older adults. So in the standards of diabetes care, I would encourage you to take a look at that chapter. And by the way, you can go online and you can look at all of this. It's free, okay? So of course, with older adults, there are some precautions that you want to take. First of all, just keep in mind that because older adults may not have the same type of fine motor skills, they may have some cognitive deficits, you really, really have to individualize their therapy. And then the biggest issue, honestly, is hypoglycemia. So older adult, you're not looking for an A1C target of less than 6 or less than 6.5 or less than 7. I would say if you had someone who was, 70 years old and they're active and they don't have a lot of comorbidities, you can push, the A1C goal. But if you have someone that has a lot of comorbidities, you want to definitely loosen that A1C goal. And I have down there 8 to 8.5%, but it's not one size fits all. So your goal is going to be kind of de-intensifying their regimen, not having someone who's, I'm not trying to pick on age, but having someone who's 80 years old doing 4 shots a day. So you want to look for opportunities to kind of help them to kind of simplify things so that they have more opportunity to kind of, what I would say, be compliant and kind of stick with the regimen. The more shots that people are on, the less likely they're going to stick with the shots.
I agree.
One of the questions was, what kind of recommendations would I make or give someone who's a new nurse practitioner and they're out in practice? Really, everything that you see in the slide deck, but specifically, it's really important to not be judgmental. And I've been there as well, where I have told people that they're not adherent, you're not compliant, kind of you, blame, when in fact we're dealing with adults. And one of the things is you want to know that adults can do what they want to do, right? You don't tell them what to do. you work with them to see what they would like to do. And you'll see that a lot in diabetes care now, not calling people diabetics because that's really a label and they're more than their disease, but saying a person with diabetes, which I know sounds like a play on words, but it really does make a big difference. Because there's a lot of language out there that's very stigmatized, and people already feel bad about having diabetes. They don't want their family members to know. It's like it's a shameful thing. And sometimes I'll go into rooms and a patient will say, I don't want my husband to know, I don't want my boyfriend, not husband, I don't want my boyfriend to know that I have diabetes, or I don't want my girlfriend, as if it's some type of defect. And a lot of that has really been brought on, I really believe, by healthcare providers, because there definitely is a stigmatizing language that's been used for a very, very long time. So I would just encourage you to partner with your patients. Don't blame them for things that are happening, because adults can make choices.
Right.
And a lot of times those choices are there, they're making those choices for a reason. Oh, I didn't take my insulin. Well, why didn't you? Well, because I couldn't afford the copay. So it's not just that they were being non-compliant. There's really a reason behind that.
Okay, so very good. So basically, to the new nurse practitioner students, leave your ego at the door pretty much and just work with your patient.
Yeah, because if you are, if they feel like they're being judged, they're not going to come see you very often. I can tell you that. And then the other thing, I'm sorry, I forgot to mention, be progressive. And what I mean by that is, I don't mean choosing the latest, greatest treatment for diabetes. What I mean is that if something isn't working, don't wait a year or 2 years to change the regimen. And I see that all the time. How long have you been on this insulin regimen? Oh, for about 2 or 3 years, but your A1C is 9. So
right.
Something's not working. So you really have to, there's a lot of tools out there. There's a lot of different oral medications out there. Please be encouraged to try different things with your patients, because you probably will see results. But if you're not trying anything different and just trying to push your patient to do the same thing that wasn't working, then you're going to have the patient's not going to have the very best outcomes.
Right. Okay. Very, very good.
So continuous glucose monitoring, this is something, and I don't have time to watch TV, but if you do watch TV, you will see that there's a lot of commercials I can't watch TV without Freestyle Libre and Dexcom G6.
Mm-hmm.
And these are wonderful, wonderful opportunities for patients to really kind of manage their diabetes. It's really giving them a tool. Any patient that has type 1 diabetes should be on a continuous glucose monitor, period, hands down, even if they're not on a pump. But what we're seeing is that a lot of patients with type 2 diabetes are using these. And what they found is that by using this, patients can kind of not necessarily react to blood sugars, but be more informed about what's going on when they eat certain foods, when they exercise. All they have to do is scan it, and it will tell them, oh, I just ate that bag of chips and now my blood sugar is 250. Maybe I should cut back, or maybe I should portion control. So these are a great opportunity. Lots of insurance coverage for Medicare, which is, of course, is our largest population. If a patient is on multiple daily injections, it's probably going to be covered. Private insurance tends to follow in the footsteps of Medicare, so it's definitely something that's worth looking into for your patients. And there are a lot of different ones out there. You know, if you write the prescription for the Freestyle Libre, the patient literally takes it to the pharmacy, and trust me, they can figure out how to use it. The other ones are a little more involved, and you would probably need like a representative to come and work with the patient. But the Freestyle Libre, I would say, I can say this, is absolutely the cheapest, and it's the easiest to use. So the sensor that you pay a one-time cost for is usually less than $100, and that's what you use the reader that you pay a one-time cost for is usually less than $100, and you use the reader to scan the sensor. The sensor is changed every 14 days, and you basically need 2 sensors a month. And usually, for cash pay, the 2 sensors a month would probably be over $100. But if you have insurance, of course, it would be a lot less. So the Freestyle Libre, I think, is a great opportunity.
Okay. Very good. Oh, you got dark.
I'm sorry, I got my lights off. I went by. Let me turn my light on. Hold on. The sun went down and it caught me off guard. Sorry about that.
That's okay. Okay,
Yeah.
so that was fabulous. Thank you so much. That was so much to unpack, so much information, and I'm so glad that we're recording this so that the students have the opportunity to rewind and look at it often. The last question I have before we conclude for this evening is there any tip that you can give us to either keep kind of this, in our heads, or to keep it all together? Or do you just recommend that we go to the guidelines when we need to, do some prescribing?
So you're going to get really good at it. I mean, especially nurse practitioner, once they're out there, you're going to deal with diabetes all the time.
All the
And
time.
perfect practice makes perfect. So you're going to start off looking at your algorithm, looking at your guidelines. Like I used to keep mine on the bulletin board, or I would go on my phone and look at my app for the American Diabetes Association. So it was very handy. But over time, you're going to become very, very comfortable with it. So I would just encourage you to start off looking at the guidelines, but beyond that, you guys are going to be wonderful.
Okay. Thank you so much. Thank you so much, guys, for watching. Thank you, Stacia. And if you like this content, please leave some comments below. Leave some comments for Stacia and questions that we can follow up with her. And we just thank you all for being here, and we thank you for watching. All right,
Thank
Stacia,
you.
take care. We'll
Bye.
talk.